Hi everyone, good morning again. My name is Dr. Anthony, and I'll be doing the introduction this morning. So it is my distinct pleasure this morning to introduce our speaker, Dr. Larry Amsel, presenting today on a theoretical distinct model of suicide. So Dr. Amsel is an assistant professor of clinical psychiatry at Columbia University. He studied mathematics before completing his MD at Yale University School of Medicine and his MPH in biostatistics at Columbia University. At 7, trained thousands of community clinicians in evidence-based treatments for PTSD and Complicated Grief. His research applies decision science tasks psychiatric research and explores the role of biological mechanisms and decision science of suicide prevention. Dr. Amsel has devoted in his studies examining the lifelong effects of children's mental health as the Associate Director of the Global Psychiatric Epidemiology Group at Columbia. So today, again, Dr. Amsel will be speaking on a theoretical decision model of suicide. For physicians who will be, this session is actually standing present, so for physicians who will be requesting the credit, we ask that you sign in on the sign-in sheet in person, or if you're on Zoom, we ask that you only type your name and email in the chat at the beginning of the session. Thank you.
So we're gonna, the title of the talk is Can Mathematical Decision Theory Explain Suicidal Behaviors Better Than Conventional Theories? So our goal of this research program is to get psychiatrists to combine decision theory and psychiatry, including math modeling of psychiatric phenomena. We want to present a formal decision theory and a game theory model of suicide and demonstrate how this can add to our understanding of suicidal behaviors from ideation to suicide mortality, help in our prediction and prevention and treatments. So it's an approach that's going to try to help us understand suicide in a more comprehensive fashion. And I want you to consider how the work that you're doing on suicide may interface with these ideas. So here's the outline of the talk. And we'll start with why is decision science central and what is the nature of behavioral economics. We'll then move on to how decision trees explain choice behaviors, do a math modeling of suicide, then do an expanded math model, talk about game theory and implications for understanding suicide. So understand that decision theory is the love child of economics and psychology, that these are two related fields which are have been separated, but are now coming together. Economics is not the study of money. Economics is a study of behaviors involved in the use of scarce resources. It's not only about money, as I just said, and not even mainly about money. It's about behavior around scarce resources, which essentially is life. It assumes rationality, and that's how it differentiates itself from a lot of other things. And all that means is that humans act to achieve their goals. People have a lot of arguments about what rationality, if people are or aren't rational. When it comes down to it, what rationality means is that humans act to achieve their goals. Everybody seems to agree that they do that, but then they have lots of arguments about what rationality means. This assumption that humans act to achieve their goals makes it possible to use a math model. Without the rationality assumptions, it's more difficult. So classic economics is also not an experimental science. It uses data, but it's not generally experimental science, at least not classic economics. We'll talk about the changes. Psychology is a scientific study of the mind and behavior. It usually assumes limited rationality, if any, and focuses on the prominence of emotions, at least in clinical psychology, that's true. Models tend to be verbal models. People just explain, like Freud explained what their models are in words. Maybe they use diagrams, but there's generally no mathematical modeling involved. The experimental approach, unlike economics, is the mainstay of the science of psychology. Over the last few decades, however, there's been this merging of economics and psychology, both in subject matter and in methodology. In the subject matter, economists are taking on more and more non-monetary subjects. Think of Freakonomics. Psychologists, on the other hand, are taking on more and more of economic subjects. For example, behavioral finance is a melding of economics and behavioral stuff coming from psychology. So that's true in the subject matter they study. How about the methodology? Well, economists are taking on experimental methods for the first time, and it's called experimental economics, and it's becoming a subject onto its own. And psychologists are taking on some of the formal modeling of decision science, including decision trees, game theory, reward learning are becoming important aspects of psychology borrowed from economics. Psychologists are also using empirical formal laboratory, that is to say, economic tasks, which we use, delay discounting, prisoner's dilemma, other tasks borrowed from economic theory, but used as experimental tasks. So the psychologists have taken some of the ideas and turned them into experimental tasks that can be done in the human laboratory, so that economic ideas are applied to psychological terms. Many of you have heard of the notion of computational psychiatry, or as I call it, mathematical psychiatry. And here's a very brief history. I think for me, one of the earliest people is George Ainsley, who coined the term picoeconomics. And the picoeconomics postulated that there was an internal marketplace, that there were many competing agents or many competing selves pulling in different directions within a single individual. And he brilliantly used economic market models to explain the behavior of a single individual, saying that individual actually contained multiple different agents pulling in different directions, and that they had to work that out. I came to the field in 2002 and used the word mathematical psychiatry to describe this merger, and suggested that many psychiatric disorders are actually pathologies of decision making. In 2015, Quentin Hughes published the term decision theory psychiatry, and he used that to explain his modeling of major depression. And then the field exploded, and borrowing from the terminology of computational cognitive science, the term computational psychiatry became in much broader use. Moving on to the second part of the talk is, how does decision trees explain decision making? The key to understand decision models is the decision tree. When we make decisions, this postulates that we have this kind of tree inside our heads, in what we call decision space inside of our heads, and we help these trees mentally make our decisions. So let's think of a simple decision. I have to make a decision where I'm going to dinner. I can go to Tom or I can go to Sam. Now, Tom's restaurant only has fish. Sam's restaurant has steak and vegetables. And they don't always have the steak. They only have steak 40% of the time. So there's a probability of 0.4, especially as the evening gets on later. And that's on my situation, is it's late in the evening, and I know by now they've kind of run out of steak and they only have a 40% chance of having that steak. So how do I make this decision? Well, the challenge of decision making, and the challenge of decision making is also the challenge of life, is the fact that there are many outcomes for any action. Notice that if I take the action of going to Sam's, I can have two outcomes. I can end up with vegetables or with steak. So one can only make choices over actions. I can't choose what the outcome is, because most of the time I take an action and then probability takes over after I've taken the action. But humans don't have preferences over actions. We have preferences over outcomes. So I can only choose actions. But what I'm really interested in is my preferences over the outcomes. And that's the dilemma. So I also need, in order to make these kinds of decisions, we usually take this completely for granted, but I have to have the valuations of the outcomes. I have to know what my preferences are. And there are two ways of describing this. One is an ordinal value, which is just preferences. I just say, I like fish better than veggies. The other is to actually give a cardinal value, an actual number, to what my value for fish is. For example, let's say my value for fish is $25. And when I have the value, then I compare it to other values. But sometimes I don't know that, my exact value. I only know my preference order. I hope that's clear. Now, this decision tree looks like a trivial event, but actually it's quite complicated. So let's look at it in greater detail. There's four things to notice about this. First is I have a choice node. That is a node where I have to make a choice. The second thing is to notice is that there are branches. Once I've made the choice, I'm sent down a branch. These are alternative futures, and I get to choose which alternative future I'm going to take, although I can't have full control over the outcomes. The next thing that I need to notice is there's probability nodes. That is, after I've made a choice, let's say to go to Sam's, there's a probability node whether or not I get the steak or I get the veggies. So life is full of uncertainties, and these probabilities sometimes are known or not known. And I have to learn what these probabilities are. And we actually spend a good amount of time in life learning what those probabilities are. I find out what is the probability of getting there faster if I take a subway or I take a taxi. I learn these probabilities, and it's a lot of my time, and cognitive work is actually based on creating models of the world by learning what the probabilities are. The fourth thing is what we call the leaves of the tree, which are the final outcomes. And of course, what's important is the value, as we've just been talking about that, of these outcomes to the decision maker. Now, just like learning probabilities, a lot of life is about learning and revising the values. I learned at some point that I like fish better than I like chicken. And I may have to revise that, but I learn these values over time. How do I do that? There's the sources of the agent's preference have to do with these cognitive modalities. I have reward learning, there's habit formation, there's fear learning, associative learning, feature extraction, in which I extract features of a situation so I learn whether to like it or not. So let's look at this, with that background, let's look at this decision again. If I choose Sam's, notice what happens. I'm going to get steak with a frequency of P and veggies with a frequency of 1 minus P. Is this acceptable to me? Well, the answer is it depends on the probability, right? If I really like steak and the probability is down to 20%, chances are I'm not going to like it. So in a situation in which I'm facing a decision under uncertainty, that is, I have a decision node, but there's also a probability node, I have a lot of trouble making that decision, often without knowing what the probability is, but not in every case, as I'll show you. Now, notice that in this simple decision situation, there are 3 possible outcomes: fish, steak, and vegetables. Simple combinatorics in mathematics will tell you that 3 things can be ordered in 6 ways. So I can have 6 people who have different order preferences for these things. And the current model implies that there are 6 types of agents, and these agents can be divided into 3 subclasses. So here are the 6 different ways in which I can have a preference ordering over these outcomes, and I order them according to this scheme, whether or not fish is first, fish is last, or fish is in the middle. So in 2 of the cases, fish is in the middle. That is the case where, for me, fish is my first preference. After that's veggies, and I'm not a meat person, so it's my last preference. In that case, I'm obviously going to prefer fish, and I'm going to go to Tom's. I could also have a situation in which fish is first, I like steak second, and I hate vegetables. I'll also go to Tom's. So anytime that fish is my first choice and it dominates over the other 2 choices, I don't even need to know the probability. I'm going to Tom's. What if fish is my last choice? And there are 2 ordering possibilities with fish as the last choice. In that case, I'm going to Sam's restaurant regardless of the probability, because fish is my last choice. Why would I go and get fish when I prefer fish as my last choice and I prefer the other 2 choices? If I go to Sam's, I'm going to get a better choice either way. So those are the cases that are kind of uncomplicated, because I can make my choice without knowing the probability. But notice that if fish is in the middle, and there are 2 ways that it can be in the middle, then I have to know what the probability is in order to make my choice. I don't have a dominant situation, and I need to actually know what the probability is that if I go to Sam's, I'm going to get either steak or vegetables. Because let's say the situation where steak is my first choice and fish is my second choice, well, I could have a situation in which I'm going to Sam's and there's a very low probability that I'm getting steak. So even though I like steak better than fish, but if there's a low probability for it, I'm going to go to Tom's. So I hope that's clear. And you'll see this structure, this simple structure that I have 3 outcomes and I have 6 types of agents who have 6 different types of preference systems. You'll see that becomes important in a moment. So oftentimes choice will require knowledge of the probabilities, just as you need to know the probability of rain when you're deciding whether or not to take an umbrella. Now, an elementary theorem of algebra will tell me if I have 3 things in order, A is greater than B greater than C, that there is a P, there is a probability such that the middle choice, B, is the weighted average of A and C. The middle choice is just can be formulated as a weighted average. If you think about this a moment, that makes perfect sense. It seems almost trivial that I'm going to be able to come up with a ordering such that the middle value can be represented by a weighted average of the extreme values. So if my preference for fish is between steak and vegetables, then there's a probability at which I have what we call equipoise or indifference between the choices. And that's where fish is equal to the certain probability of steak minus the probability of vegetables, because it's always, if the steak is available with probability P, clearly the veggies are available with probability 1 minus P. So this is where I get to be at indifference between the 2 choices. Okay, what about suicide decisions? Do they work similarly or are they very different? Well, the answer we're going to give you is, and when I first presented this to suicide people and talked to them about decision making, they absolutely rejected. The top suicide people in the world absolutely rejected my hypothesis that the decisions about suicide are made like decisions about other things in life. But the question is, we don't have 2 brains, one that makes decisions about suicide and one that makes other decisions. We have a decision-making mechanism. That's what we have in our brain. And it applies across the board. It can be a very complicated thing, but it applies across the board. So the analysis of a decision of how to go to a restaurant may have strong implications for the analysis of the decisions involved in suicidality. Well, in suicidality, I have what I call the prediction problem. And that is that there are 5 possible states: a no suicidal ideator, someone with suicidal ideation, low or high lethality attempter, and person who have mortality because of suicide. And I can switch between these states. I can't come out of them, obviously the mortality state, that's the one I can't come out of, but I might switch. And people do in fact switch between these states. The probabilities of switching from no suicide to suicide, or the probability of switching back or switching from suicide to low lethality attempts, these P's are really what we're trying to do when we talk about understanding suicide or predicting suicide. But these probabilities and the conditions that drive these probabilities are not that well nailed down yet. So when people first started thinking about using decision theory to think about suicide, they got stuck, because if my decision is, I like the status quo, or I can make a decision to die. And this is the way most suicide researchers actually think. This is the model in their heads, that a person is deciding between living, which is the status quo, and dying, and that's their choice. So there are 2 cases: people who prefer death, people who prefer life. This is not informative. This is trivial, and it's not informative. And it's also, as I told you before, it's not what's going on, because people do not choose outcomes, people choose actions. There have been several attempts at this, different kinds of using economic models to try and get extract some more meaning out of that. And I will point to, so there are a lot of people who came before me and worked on these things. My own model started up in 2001, and they were based on Nash equilibrium, which is a concept out of game theory. So here's the simple thing. Here's the Nash equilibrium model. The decision is not to live or die. The decision is to attempt or not attempt. Like everything else in life, I make choices between actions, not between outcomes. So I can decide not to attempt at any given moment, or I can decide to attempt. Once I decide to make an attempt, there's a certain probability whether or not I will survive, which I call the new status. Surviving suicide is called the new status, or death. So like the restaurant thing, I'm not to trivialize suicide, but just to try to understand the formalities of decision-making, there are three possible outcomes here. So the key insight is that we choose actions, not outcomes, and the real decision is whether or not to make an attempt. It's a decision under uncertainty. And the solution is a mixed strategy in which dying and surviving are both possible outcomes. The decision maker chooses not to attempt or to attempt. And also, and this is the key point, the decision maker also chooses what the probability is of the attempt being successful. I can choose a high probability attempt or a low probability attempt, very low probability attempt or a very high probability attempt. So unlike the restaurant, in which the restaurant is in charge of the probability, in this model of suicide choice, the attempter is the one who controls the probability. Not completely, I don't have a complete control over it, but I have a lot of control over what the probability will be. And then chance will take over, of course, and the ultimate outcome will depend on how that probability falls. So this is the razor's edge. This model tells me that we predict that the agent will attempt suicide if there is an available one method of attempting suicide that has the kind of lethality. So the probability of the probability that we're talking about here, of course, is the probability of lethality. So the attempter will start it if the utility, that is the value. U of status quo means the value of status quo to me. If the value of status quo, the value of living right now, is less than the same thing we saw before, a weighted average of the values to me of dying and the value to me of the new status. The question is, when do I have this situation where the current status is less than the weighted average of what I'm going to get by making an attempt? These are the utilities, as we said, these are the outcomes and their values. So just to emphasize this point, the decision maker will attempt suicide when the value of life now is less than the weighted average of dying. I'm repeating myself, but it's important because this is the whole central of the first concept. So I need the expected utility, which is the expected utility of the status quo. The expected value of living for me has to be less than the expected value of an attempt. And that is when I'll try. And mathematically, that says that the utility of the status quo is less than the probability of death multiplied by the utility of death plus the complementary probability times the utility to me of a new status, and that is the status of surviving. So as I said, the structures, the architecture of the decision structure is similar, even though, of course, the consequences here are devastating, unlike in the restaurant situation. I still have that same structure in which I have 6 possible orderings. So there are people who have 6 possible attitudes. And what's so fascinating about this is it seems like it's a completely abstract notion, but it turns out that we can recognize each of these 6 types as real clinical individuals. So I could have a situation in which the status quo is preferred to the new status. I prefer to just not, I'm happy with my life. And if I had to have a second choice among these 3, I would survive a suicide attempt. Death is my last choice. I don't want that. This is just a normal person. This is you and I when we have no suicidality at all. This is the ordering in which we would order our preferences for those 3 things. So the other one is the status quo situation, but my next preference would be death, because the idea of surviving, I don't want to make a suicide attempt, but if I had to make a suicide attempt, the idea of surviving it is not as good to me as dying. It sounds strange, but it's actually the attitude of a samurai, which is to say, at the moment, I'm not having any contemplation of suicide, but I would never try a suicide attempt that wasn't completely fatal. So in this case, again, when status quo is my first preference, and you can look over here at the tree if you want to understand this, when the status quo is better to me than the other 2 things, then of course I'm going to stay in the status quo. I'll make no attempt if that's it. What happens when the status quo is the last preference? Okay, so if the status quo is the last preference and the new status or death are preferable to me, then of course I will always make a suicide attempt, and probability won't matter. The probability of that suicide attempt won't matter to me. In the third subcategory is where you have the fact that the status quo is a middle preference. And when the status quo is the middle preference, then you need to know what just as in the restaurant case, you need to know what the probability is. Well, how does this translate clinically? Well, if someone has the following ordering, really, for one reason or another, let's say it's a terminal cancer patient, their preference is for death, and that's their preference over the status quo. So the status quo will be their second choice, but being able to end their suffering would be their first choice. But they do not want to make an attempt and end up in the new status because they're afraid if I make an attempt, my new status may be that I'm injured, or maybe I'll try an attempt and I will be worse injured. So this is what we call the cautious terminal patient. And they will only make an attempt if they have a high lethality means available to them, because a low lethality means could risk them ending up in the new status. They could end up surviving a suicide attempt, which is the worst case as far as they're concerned. That is their last choice, is surviving. So they will not make an attempt unless they have a very high probability value. Another kind of agent is an agent who wants the new status. They don't want to die. Death is their absolute last choice. But the status quo, the current status quo, is undesirable to them. And they want to be in the state of having made an attempt and survived. Why is that? Well, those cases are often clinically, we call them manipulative cases. It's a terrible word, but it means that they're not really wanting to die. They're making a suicide attempt because it's advantageous for them to make an attempt and survive it, but they're not trying to kill themselves. Now, these people are the opposite. They will only make a low lethality attempt. They will, if the only means available to them are high lethality, then they won't act. They will go to the no attempt situation. So that's where it is. Now notice, when we do risk assessment, it's often on the basis of our estimates of the patient's wish to die. And we're not looking at their willingness to make an attempt, which I just showed you is a completely different thing. This model of ours shows that some truly suicidal people will not make an attempt unless the correct lethality level is available. On the other hand, some non-suicidal people, that is to say, death is not their first preference, will make an attempt under the right conditions. That is to say, P has to be high enough for some people and low enough for other people in order for them to make an attempt, but we never evaluate the utility of the new status. Very rarely do we evaluate that as part of a suicide situation. When we do, and we say, oh, the person's just being manipulative, and we tend to ignore it in thinking about our estimates of the utility. We just say, oh, they're manipulative, that's a manipulative suicide gesture. And we don't take it seriously enough and understand it in this context of decision making. So just to emphasize this, even when death is a first preference, attempt still depends on other preferences and on the available probability. So a person who has the following preference, they wish to die, and their second choice would be the new status. So either of those is fine, but the status quo is not fine. That's the last thing. So they are going to try to get out of the status quo no matter what. We call these people the hopeless. But notice, they prefer a high lethality attempt, but they will try any attempt. On the other hand, another agent who has death as their first choice, but the status quo is their second choice. This is someone we call a cautious terminal patient, as we mentioned them already. And they will only attempt if a high lethality is available. So both of these people have death as their first choice. The first type will attempt suicide no matter what suicide lethality is available to them. The second type will only attempt it if it's a high lethality. So the second type explains what the Hemlock Society is doing there. What the Hemlock Society is doing is making high lethality attempts available to such cautious terminal people. And again, they're cautious terminal because they would prefer the status quo to the new status. They're afraid of new status. New status means I've made an attempt And maybe I'm more injured and I would just be suffering more. So I don't want that situation of being after a suicide attempt and having survived it. That's not my preference. Consider that case at all. And again, we call it manipulative gesture, but it's not manipulative. It's a signal, it's a sign, it's a communication. These people are willing to take a low risk of death, and they are willing to take a low risk of death, only a low risk of death, in order to achieve other goals, namely the new status goal. But lethality must be below a certain cutoff for them to take this action. Again, they're willing to take a risk of dying, but their real goal is to make an attempt and survive it. And they are limited to low lethality methods. An example that I had in the emergency room was an adolescent Hispanic woman whose parents wanted her to go to the senior prom with a chaperone. She was so terrified about how embarrassing this would be that she made a low lethality attempt. And when we discussed it, she said, I didn't want to die, but I had to change something. I didn't know how to change the situation, and I had to do something to change the situation, which was unbearable. So she was exactly in that situation where she needed the new status. That was her preference. The status quo was unbearable to her, but she certainly didn't want to die. That was not her goal. She made a low lethality suicide attempt. The family got together and they understood the signal that she was in a great deal of distress over this senior prom and let her go to the senior prom without a chaperone. This slide just emphasizes the same points. So the final implication is that the model predicts that one could reduce the risk in the manipulative type by reducing the value of the new status. And that's consistent with Kernberg's, many of you may be familiar, is Kernberg was one of the most famous psychoanalysts in America in the last 30 years. And he would design a therapeutic framework for suicidal patients in which he said, if you make a suicide attempt, then the therapy with me is over. I'll help save your life, but the therapy for me is over. Why did he do that? Because he wanted to reduce the value of the post-suicide status. And he created a framework in which he wanted to reduce that. So he didn't realize it himself, but he was working with decision theory to change the parameters. There are some more technical points here, which I'm going to skip over. But I want to talk about the cautious terminal patient for a moment and see what are the implications now for that patient. Well, this decision maker prefers death to the status quo, but is fearful of post-attempt damage to himself or to others. And counterintuitively, even though he really wants to die, will not make an attempt unless there's a high certainty of success. This squares with literature which indicates that elderly terminal patients rarely make a low lethality suicide attempt. Pashidi, in a 2000 article, showed that somatic anxiety was protective against attempts, while generalized anxiety or panic disorder were increasing attempts. So why was somatic anxiety protective against attempts? For exactly this reason. People who are very, very worried about the condition of their body, even if they have a desire to end their life, may not do it because they're afraid that they'll survive in worse conditions. And again, to emphasize, the point is that many of these factors that I am pointing out that will either promote or prevent an actual attempt are not assessed because we are focused exclusively on asking the person whether they have a wish to die, which, as I'm showing, behaviorally doesn't correspond. Okay. So I hope you understood that model. So if you've got that point, we can go to an expanded model. The expanded model is called a Markov model. And the problem with the previous model is that it assumes when I make the status quo choice, that is a stable choice and it's permanent. So one of the branches had a probability node. The other one had no probability node. A more realistic model includes the fact that a patient's status changed and they have some expectation of that possibility. So what is this? What is the expectation? That's called hope, or its opposite, hopelessness. And that's the way I'm going to expand the model. This is a Markov model. I'm in a state and I move between states in Markov decision models. So I'm in a depressed state, focus on this, and I have an R probability of recovery. R is the probability of recovery. Once I'm recovered, I have Q, and probability of stable recovery, or 1 minus Q, probability of relapse. Similarly, when I'm in the depressed state, I have a 1 minus R probability of staying depressed, which is the complement of the probability of recovery. What does this look like? It introduces new parameters that I have to worry about. And some of those parameters involve the question of hope. And also the question of things that happen in the future. So it introduces the idea of delayed discounting. Together, it becomes a formal model of hope in the suicidal situation. What does it look like as a tree? Well, before I had the attempt for the probability of dying, there it was. But now I have the no attempt. What happens here? Now I have two possibilities, not one single stable possibility of a status quo being stable, but rather I could have a stable a status quo that's here, or I could have recovery. And R is the probability of recovery. This thing is the probability node here of recovery. So I could have the status quo. Now, if I'm in the status quo, I make no attempt, I'm in the status quo, then I'm back to the beginning. I'm back in the same situation where I started the decision. And that's what this little diagram shows, is that I'm back at the beginning of the decision cycle, right? So I have the whole tree back again, and then the tree is again embedded if I stay there, and embedded, because the entire decision tree is embedded here. So if I do not recover, when I decided not to make an attempt and I'm stuck in the status quo and I haven't recovered, then I'm facing the same decision again. And I'm facing the same decision again. Remember, it has many branches. And among those branches, I'm pointing out that the value of death is there as well. If I have a high value, a high utility for death, that high utility for death is in that next cycle as well, only it's delayed. The other possibility here is the recovery, right? That instead of staying in the status quo, I've made no attempt because I believe there's a good probability that I will recover, in which case my utility is for the utility for recovery, and that is the value that I get. I end up as a recovered individual. Obviously, a lot of people will have a very, very high valuation for that recovery. So there's an unexpected explanation that falls out of this model, namely the protective effect of the future potential attempts. By waiting and not taking the action, I can still achieve all the various desired outcomes only later. I can have a later death or a later recovery. So discounting the future value plays a role. Now, interestingly, Nietzsche noticed this, and he said, suicidal thoughts have gotten me through some bad nights. And one of my patients said, the only thing that keeps me from attempting suicide is my suicidal ideation. I could do it tomorrow, and I hold on to that one day at a time. Why do doctors want to take my suicidal ideation? It's the only thing that's keeping me alive. What she means is that because this has value to her, because the possibility of a future suicide thing has value, that value loads on to the no attempt branch. This is a little confusing if you're not used to dealing with decision science, but when you're doing with decision science, all the values that go into this branch load onto this branch and will pull you away from the attempt into this direction. So the possibility of a future attempt actually loads onto the current no attempt branch. Now, how do I learn about this recovery? What evidence and algorithm do I have to estimate the probability of my recovery? Well, it's probably a Bayesian approach. I start with a prior estimate of recovery, called the probability of recovery, and I then use evidence because I haven't recovered in the last week. So that's evidence. So if E is the event or the evidence of non-recovery in that week, then the probability that I would not recover is the probability of having that event, given that the probability of recovery is R. So this is a typical Bayesian updating. Those of you who are familiar with it will appreciate it. And if you're not, don't worry about too much about it. The bottom line is that every week I go back and I reconsider what my probability of recovery is. I reconsider my hope and reevaluate that hope. And by reevaluating that hope, if I had a certain estimate for the probability of recovery and I didn't recover during the next week, necessarily my probability will go down. So every week, my hope goes to, every week I don't recover, my hope goes down. But unfortunately, it's worse than that, because the question is, how frequently do I reconsider this estimate? It may be that this reassessment is accelerating, because when you're in pain, a day feels like a week. So as I feel more desperate, I increase the frequency of my updating. Maybe I'm now updating every day. And if I'm updating every day, then my internal estimate of the probability of recovery, it'll go down less each time because it's a day and not a week of evidence. But nevertheless, that cycle can be very, very strong risk factor, because it'll cycle down, and my probability estimate, internal probability estimate, is Bayesian updating in a negative direction every week and every day and every hour that I don't recover, because those are evidence that my probability was too high. So that's the Markov model. And if you're still with me, we'll look at one further model, because these models were good as far as they went, but what they did not take into account is other people. There are other human beings, and when people make suicide attempts, they have other people in mind sometimes. Sometimes not. Sometimes people are so desperate, their pain is so bad, that even though they know this will harm other people, they just have to put the other people out of their mind, because the pain is so unbearable that they simply have to take their lives, even though they know that's going to hurt other people. And sometimes the other people don't matter. But sometimes the other people do matter, and especially in the case what we called before as the signaling case or the manipulative case, it's other people's reactions that matter. So in game theory, it's not one decision making, it's two decision makers, and one person's decision making depends on the other person's decision making. So let's look at how this is going to look. I have what we call player one, and I'm sorry, this is terminology that feels inappropriate for suicide because it's a player, as if it was a game. It's not a game, but this is the technical terminology from game theory, is that you have players. So that's the terminology I'm going to use. In this case, I hypothesize I consider three things. I consider no attempt, which is the status, I'm stuck with the status quo, or I consider a low lethality attempt or a high lethality attempt. Now, I might consider these attempts. We said before that certain probabilities of attempt may inhibit me or may promote the thing. But in this case, I'm thinking about the other person's reaction. So if I make a low lethality attempt, I may survive or not survive. If I don't survive, that's the end of the branch. But if I do survive, then player two gets to make a choice about me. I've survived the suicide attempt. Is that person empathic to me, or is that person angry with me? Now, I may make a calculation that if I make a low lethality attempt, the person will see it as a manipulation and be angry with me. Whereas if I made a high lethality attempt, that person will take it as a very serious suicide attempt, and instead they will be empathic to me. So that's where the signaling game comes in, which is to say that I may be calculating another person's reaction to myself in choosing whether or not to make an attempt, and in choosing the probability of that lethality. This is a little bit difficult because I'm trying to put all of those things now into a tree. So let's look at the possibilities. One is I make no attempt, I make a low attempt, or I make a high attempt. If I make no attempt, again, I'm in that cycle of I'm in either recover, which is fantastic, or I'm in the status quo, in which case I cycle through this decision again. What if I make a low attempt? Well, there's some probability that I will pass away anyway, that it will be fatal anyway. But the other possibility is that I live. And in this case, it's not that I live in a new status, because I'm now taking into account that another person makes a choice about how to react. So that my value for the new status depends on how the others react to a high versus low lethality attempt. And I have to balance, in doing this strategically, I have to balance my credibility with my safety, which may be pulling in opposite directions. Again, because I may not wish to die. I may wish simply to signal how distressed I am, but I may have to take a real chance in doing that and make a high type lethality attempt in order to convince the other person that I was serious about this. So as in all signal games, there's asymmetric information, and the second player, the clinician or family member, doesn't know what the intention is, and the first player is going to have to choose a probability in order to send the right signal. The lethality level is chosen depending not only on the acceptable risk level for that person, but also on the first player's belief about the second player's reaction. And there are cultural conventions around this. So in summary, decision theory models of suicide behavior are consistent with published phenomena, and they may lead to an improved ability to predict and prevent suicidal behaviors, because I think, as I've shown you, contrary to current assessment models, they have a much more nuanced and complicated approach to understanding the decision process. So they may help understand certain suicide behaviors that appear anomalous by the current models. They may be best understood using these normative models, and the perspective has a large intellectual convergence with mathematical psychology, decision theory, and behaviorism. So I hope that it's a contribution to the system. I've left a couple of poems here, but in the interest of time, we'll go straight to questions. Who is monitoring the questions for me?
I have a question. It's about non-suicidal self-injury, which
Not a topic here.
No, but I think you're
non-suicidal self-injury is beyond the thing. In non-suicidal self-injury, the utility of death is off the table. I have no thing. So that model is very, very different, because in those models, I
talked about low lethality attempts.
Yeah, but it's not. In those cases, the utility for death is zero. It's off the table. I have no. Non-suicidal is non-suicidal. That means I have no. There's not a conflicting value or even a low value for the possibility of death. It's off the table. It's not part of my decision making. It's not part of my decision making. Now, you could say that it is possible when I cut myself that I could die. But the probability there are so low that I think it requires a whole different model. I've thought about that, and my decision is to leave that out of this consideration, because I think that the decision's architecture there is different. But thank you for the question.
Thank you, Larry. From Guyana, we're here. We really appreciated that presentation. It really explains a lot of cases of suicide attempts. I think clinically, when you're exposed to those types of patients, it explains a lot. So my first question, I have several, but my first question is, how do you think this will vary or be moderated by?
I'm sorry, it's a little hard to hear you. Slow down. Say that again. The first question is what?
How do you think this model varies, or does it account for any moderation by cognitive maturity, such as age and education?
Well, I think those are wonderful questions, and those are wonderful questions. And of course, I've not taken any of that into account. I've given you a model for kind of a quote unquote an average cognition person. But you're absolutely right that there's impulsivity in adolescence. The impulsivity in adolescence will play a role in this kind of a thing. Adolescents are much less able to estimate actual probabilities, and that's why they're high risk takers, because they don't actually understand the probability any action will have on negative outcomes. So they're bad at estimating probabilities. And like I said, one of the things that we do in a life of understanding decision making is I'm constantly learning about the probabilities in the world, and I'm learning about the values to me. Adolescents haven't had time to really learn what is of value to them and what's not of value to them. So that is a factor that has to be taken into account.
I have a question. So in this model here, in the accept branch, Actually, you go to the other model that you included for the no status, for the status quo, that I think it's the Markov model. Can you go to Markov model?
Give me a second. Yeah, here's the Markov model.
Yeah, so the arm where you have the recovery, and you have the additional attempts, that same sort of branch also should be down in the attempted for those that do not die from suicide. Because as you very well know, a high indicator of someone who's going to die from suicide is if they had a prior attempt. So I think that branch of the delayed recovery, that you have with the Curlys also should be in the non-death side of the attempt. And does that then, the next attempt, does the probability change that they will actually die from suicide? Because they have learned.
So what you want me to do is you want me to have another probability node branch over here. You see where I'm adding an arrow? What
Yeah,
you're saying is
exactly.
after recovery, I'm going to have the same kind of situation where there's recovery or not recovery in that thing. And you're right. I didn't consider it past the one decision so that I could start over. If a person has recovered from suicidality, what is their decision-making point? What does their decision tree look like starting after they have made the attempt? You're absolutely right. It would just be too complicated to look at, and I haven't gone down that road.
More importantly, does the probability of dying from suicide then increase because they have made a prior attempt, which I would assume yes.
Well, clinically, it works both ways. Clinically, people who have tried an attempt have a higher, anyone who's made an attempt has a higher risk. But it's unclear whether the reason is because the prior attempt tells us that they have suicidality, or whether the prior attempt actually increases. You see that, whether it's causal or it's just the signal for an underlying situation. So it's not clear whether to me, it's not clear whether a prior suicide attempt actually in and of itself increases the suicidality. A lot of the people that I've met over the years have, after they've made a suicide attempt, have said, I did that and I'm so glad I recovered. Not everybody, but a lot of people have said, I'm so glad I recovered. So I think
You're right, Larry, Ellen here. I think one of the psychological ways of speaking about that is that the new status merges both in the psychological literature, escape, Bormeister's escape, as well as pain threshold. What was their pain threshold? Because that's going to determine the lethality.
Determine the what?
The lethality of the attempt. So, for example, when I've interviewed patients in the ED who've attempted suicide, we ask the question of how much of you actually wanted to die. And we only consider for intense treatment those who say 50% of me or more. I don't know if this is what Larkin was getting at before, because some people will say 40% of me wanted to die, and sometimes that's not considered an emergency situation. That's not considered a suicide attempt, a full attempt, even though it landed them in the emergency department. But specific to your model, having a prior attempt that was painful and they could not endure the pain, puts them in a new status where the escapism, the escape of the status quo is diminished because of their pain threshold.
Yeah, well, first of all, my model accounts for that because that's the situation down here. If I can get back to that model, that's the situation back down here where somebody has a first preference for death, but the status quo is their next thing, and the last choice is the new status. Well, if there's a lot of pain involved in making the suicide attempt, that's where a new status would be. That's the same thing. So that's on that branch. When I'm thinking about that, the attempt of the new status would include all the pain I experienced would be loaded into the new status, right? And so
Yeah, I'm saying the new status you have here includes pain threshold, prior attempt, and escape. Escape from the status quo.
So what you have to understand is that this model is different than the existing models. In this model, you wouldn't ask somebody whether how much of themselves wanted to die. You focus on what their order of preference is. So it's quite a different model. And the anticipated pain in this model, the anticipated pain of making a high lethality, if I'm trying to cut myself, an anticipated pain, all of that anticipated pain goes into the branch of the new status. Okay, because the pain would not be experienced if the person died. So all of that pain and the anticipated pain for the future would be part of the new status in this model. I think the model does capture that. I didn't discuss it, but I think it does capture all of that in the new status value.
Thank you. Yeah.
Oh, thank you for that, and thank you for your questions. So we are getting close to wrap up time, so I don't think we'll have time for more questions, but I just wanted to say on behalf of the entire conference organizing team and the Guyana Wellbeing Project team, thank you so much to you, Dr. Amsel, for all of your presentations this week. You have been really, truly great, and I'm sure that everyone who has attended your sessions really learned a lot. They were very valuable presentations. So thank you for that, and thank you to everyone for attending this morning.